cover enzyme deficiencies, clinical presentation, pathophysiology, and treatment. Question 1. Clinical presentation in organic acidemia. A 5-day-old neonate presents with poor feeding, vomiting, hypotonia, and seizures. Labs reveal a high anion gap, metabolic acidosis, ketonuria, and hyperammonemia. What is the most likely underlying diagnosis? A. Galactosemia. B. Glycogen storage disease type 1 Gierke. C. Organic acidemia. D. Congenital adrenal hyperplasia. E. Urea cycle disorder. C. Organic acidemia. Explanation. Organic acidemias, such as propionic acidemia and methylmalonic acidemia, classically present in infancy with poor feeding, vomiting, hypotonia, high anion gap metabolic acidosis, ketoacidosis, and hyperammonemia. Why not the others? A equals presents with hypoglycemia and liver failure, not acidosis. B equals severe hypoglycemia without acidosis. D causes electrolyte abnormalities, but not acidosis with hyperammonemia. E, hyperammonemia without high anion gap acidosis. Question 2. Vomit substrates and treatment. Which of the following amino acids or metabolic products should be restricted in a patient with propionic acidemia? A, valine, odd-chain fatty acids, methionine, isoleucine, threonine. B, phenylalanine, tyrosine, tryptophan. C, leucine, lysine. D, glutamine, alanine. E, arginine, aspartate. Correct answer. A, valine, odd-chain fatty acids, methionine, isoleucine, threonine. Explanation, mnemonic vomit. These substances are metabolized into propionyl-CoA. In propionic acidemia, the enzyme CHA-propionyl-CoA carboxylase is deficient, leads to accumulation of propionyl-CoA, metabolic crisis. Treatment includes low-protein diet, limiting vomit substrates. Why not the others? B equals involved in aromatic amino acid metabolism, PKU. C equals ketogenic amino acids, not glucogenic. D, E, not major contributors to propionyl-CoA. Question 3. Methylmalonic acidemia versus propionic acidemia. A 1-week-old infant has vomiting, lethargy, hypotonia, and a high anion gap acidosis. Labs show elevated methylmalonic acid and normal propionyl-CoA levels. What is the most likely deficient enzyme? A, propionyl-CoA carboxylase. B, methylmalonyl-CoA mutase. C, glucose-6-phosphatase. D, carbamoyl phosphate synthasing. E, ornithine transcarbamylase. Correct answer B, methylmalonyl-CoA mutase. Explanation, methylmalonic acidemia is caused by deficiency in methylmalonyl-CoA mutase or vitamin B12, leads to buildup of methylmalonic acid, similar symptoms to propionic acidemia, but with methylmalonic acid as the key marker. Why not the others? A causes propionic acidemia, not methylmalonic. C in Gierke disease. D equals urea cycle disorders, usually without acidosis. Question 4. Metabolic consequence of organic acid accumulation. Why do patients with organic acidemias develop hyperammonemia and hypoglycemia, especially during fasting or illness? A. Organic acids activate insulin release. B. Organic acids inhibit ketone body synthesis. Organic acids inhibit the urea cycle and gluconeogenesis. D. Organic acids stimulate fatty acid oxidation. E. Organic acids enhance glucose uptake into muscle. Correct answer C. Organic acids inhibit the urea cycle and gluconeogenesis. Explanation, accumulated organic acids inhibit gluconeogenesis and urea cycle enzymes. This leads to low blood glucose and elevated ammonia, results in metabolic acidosis, hyperammonemia, and neurotoxicity. Why not the others? E. Not accurate mechanisms in this context. Would you like a flowchart of vomit metabolism?